The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, here with another edition of Inside JACC, and I'm speaking with Chris Kramer, who's probably well known to everyone. Chris is a professor of medicine and radiology and director of the Cardiovascular Imaging Center at the University of Virginia and one of the international leaders in cardiac MR. And he's the senior author on a paper to be published in JACC that deals with quantitative CMR perfusion. So, Chris, can you tell us a little bit about the study?
Sure. We recruited 41 patients prior to X-ray coronary angiography and performed a fully quantitative stress and rest adenosine perfusion MR along with late gadolinium enhancement with the concept that we wanted to compare qualitative analysis of CMR perfusion images with quantitative analysis of CMR perfusion images to see how they fared.
Well, I guess it's intuitive that quantitative CMR images would have greater value than quantitative, but perhaps you'd review for us what the advantages were that you were seeking.
We thought that the advantage might be overall accuracy and improved specificity. Accuracy of qualitative analysis of CMR perfusion images is quite good. It has a higher sensitivity than specificity, and we thought we may be able to improve on the specificity. It turns out that the overall accuracy, when performed in our hands, was quite similar with qualitative versus quantitative analysis, but there were certain advantages for the quantitative analysis in terms of assessing this extent of coronary artery disease.
Sure. So I guess with the quantitative analysis, you could get ischemic burden, probably able to distinguish single vessel, say, from triple vessel disease. And was it of any value in distinguishing patients with balanced ischemia?
Yes to both questions. The major advantage was really assessing the extent of ischemia. For one vessel disease, the qualitative and quantitative analysis really performed remarkably similar. For three vessel disease, qualitative analysis suggested that about 25% of the left ventricle was ischemic, whereas quantitative analysis, measuring perfusion and perfusion reserve, suggested that over 60% of the myocardium was ischemic. And this points out one of the limitations of qualitative analysis of any imaging technology for assessment of ischemia. We've been very good at diagnosing which patient may have ischemia, but suggesting which segments or which coronary territories is more problematic, and the burden of ischemia is more problematic. So we think the ability to do quantitative analysis will really improve our ability to identify the patient with three-vessel coronary disease. The same can be said with balanced ischemia. We had patients in our group who had balanced ischemia by other imaging modalities, specifically SPECT, who are identified having multivessel coronary disease on CMR.
Yeah, now I think it's fair to say, Chris, that magnetic resonance stress testing has not been widely adopted throughout the country. Your protocol would involve 2 injections of gadolinium and some more complex imaging. How do you see magnetic resonance stress testing, particularly for perfusion, emerging as time goes by?
Well, I think actually this protocol that we're publishing required 4 separate injections because we acquired a arterial input function or LV input function as well as a separate injection for a tissue or myocardial input function, both at stress and rest. However, things have progressed and we now have a pulse sequence in which we can acquire both the arterial input function and the tissue input function with the same injection of gadolinium, the same pulse sequence. So that is no longer a problem. It requires an injection of gadolinium at stress and another one at rest. I think the reason it hasn't caught on as much as it might is education and training. There are just not enough centers out there that know how to do it well. Those that do have excellent results with it, and it compares favorably against other modalities, and as well in a recent paper was shown to actually perform best against FFR in the cath lab. So it really is giving you the answer about physiology. It performed better against FFR than it performed against quantitative coronary angiography, again, because we're answering questions about physiology rather than anatomy.
Well, it's certainly an attractive concept, even if it requires a couple of gadolinium injections, to use magnetic resonance perfusion to get physiologic information and to assess ischemic burden and distinguish balanced ischemia. So I think this may be yet another boost to magnetic resonance stress testing. Thanks very much for being with us. For Inside JACC, I'm Tony DeMaria.